Welcome, everyone. My name's Michael Fine. I'm a writer and community organizer, a family doctor, and a public health guy. And I'm president and board chair of Primary Care for All Americans. I'm really pleased to welcome people tonight from 26 different states in the District of Columbia and 135 different zip codes who've come together to build a movement in a healthcare system for the United States, a healthcare system that's for people, not for profit, and that starts by providing primary care to everyone in every American neighborhood and community. We're really talking about a sea change, a big new idea that we can fix the healthcare mess and make a more equal nation if we come together and provide primary care to every single person from sea to shining sea. It's now my great pleasure to introduce our moderator for the evening, Dr. Gabrielle Yaru, and to thank the Zoom Committee of Primary Care for All Americans, which organized this Zoom. Thank the amazing Dr. Adams and all the presenters, and John Wright, Brian Kaiser, and Patty Armstrong, our ACE Zoom producers. And to remind everybody to please come to our next Zoom on January 23rd and bring 2 or 3 other people. That's how movements are built, by people talking to each other, listening to each other, and talking to and listening to communities. Take it away, Dr. Yaru.
Good evening, everyone. Thank you all for joining us on this very exciting meeting. We are happy to introduce PC4AA, Primary Care for All Americans. We are building a movement to provide healthcare for all people. Healthcare for people, not for profit, in every neighborhood and community. If you have questions, please put them in the chat and we'll try to get them answered after we hear from our very special guest speaker, former U.S. Surgeon General, Dr. Jerome Adams. First, we'll hear from 3 individuals who will tell us about their experiences with primary care in our current healthcare system. Christian.
Hi, everyone. My name is Christian. I'm from Central Falls, Rhode Island, and I'm currently a pre-medical student. I'm deeply passionate about advocating for universal healthcare accessibility, particularly in the realms of primary care, with a focus on historically marginalized and misrepresented communities. Growing up as a Latino with immigrant background, my interactions with healthcare extended beyond the mere symptoms. My primary care physician not only addressed my physical well-being, but also delved into social and systemic factors contributing to my health complications, such as challenges with transportation or cost of treatment. In these encounters, my primary care physician was able to listen to me and understand me in ways beyond the doctor-patient relationship without bias or judgment. I was seen not as just a Latino patient who presented symptoms, but I was seen as a person with actual life issues. And during these moments with my primary care physician, I was cured from my illness, not just with antibiotics, but with humanity, with compassion, with sympathy. These experiences were meaningful to me because I was provided with a secure space for open conversations, opportunities to be vulnerable, and be treated for my symptoms and for potential flourishment in my future. These experiences and beliefs are precisely the reason why I find myself here with you all. I'm pursuing a career in medicine, and I'm advocating for a world where everyone in my community and everyone across states gain access to primary care. Thank you all for your time.
Thank you, Christian. Now we'll hear from Mandy Bass.
Thank you. Good evening. My name is Mandy, and I'm coming from the school nurse perspective. A healthy student is a better learner, and that's why healthcare for all school children is so important. 1 in 9 children receive healthcare through a school-based primary care center. With the rise in anxiety, depression, physical needs of students since COVID, primary care in schools is integral to the health of learners. When students do not have access to healthcare centers in their schools, the school nurse is the link between students, families, and their PCP, assuming that they have a PCP and that person is available for consultation and care. There are 3 areas of care that nurses oversee in schools: prevention, screenings, triage and first aid, and management of chronic conditions. And these are often analogous to what people see in the primary care offices: your annual visit, episodic visits when you're ill, and then chronic care when needed. So the first area of screenings address problems that hinder students' health and access to learning. That includes things like hearing screenings, vision screenings. As you can imagine, these are very important for students in the classroom as they get older, mental health screenings, drug and alcohol use screenings, and different things that help people recognize problems that can be treated so they can be learners. The second, triage and first aid, goes beyond Band-Aids and ice packs. And as Christian said, the focus on determinants of social health. Things like, are kids able to get to school? Do they have transportation? Do they have enough food so that they're not hungry and they can be learners? Different things like that, including, do they have access to health care? These are things that school nurses can track and manage, but without a system that really can take care of kids, it goes nowhere. We really need that backup and that support and that follow through. School nurses manage chronic conditions like diabetes and asthma, learning disabilities on a more daily basis. Nurses bring together teams and advocate for students, families, get involved and collaborate with healthcare providers when it works well to make sure that the school is a learning environment and a caring environment. So health clinics in schools and school nurses provide timely and relevant individualized care, but desperately need the support of systems and more primary care providers to assure that all students can be the learners that they're possible to be. Thank you.
Thank you, Mandy. Now we'll hear from Eliana Bressler. Eliana.
Hi, I'm Eliana, and I live in Pawtucket, Rhode Island, and I'm a lively 70-year-old, and I'm reading this because I'm nervous. And I have been living with multiple chronic health conditions my entire life. I had a wonderful primary care doctor for 27 years, which was really good because it was both for maintaining my physical health, but also my sanity, as the young man mentioned. She was knowledgeable. She was also respectful, even when we disagreed, and she turned out to be right. She once told me when I was having one of my bad days that you manage so well, people do not understand how many challenges you're up against daily. Her expertise and perspective were a big help advising and partnering in my care so I could manage that well. When you're older and you have continual health challenges, it is so important to have one primary care doctor who gets to know you so you don't have to spend most of your skimpy 15 minutes that insurance gives you on your medical visit on relevant medical and health history and barely leaving any time to get to the whole point of the visit. Then last December, my doctor retired. I've been looking for an appropriate replacement since then. Doctors specifically recommended to me by friends were not taking any new patients. Someone recommended an all-woman practice to me. When I checked them out online, I saw they actually listed a doctor who said she helped people with chronic health conditions. So I called for an appointment and she was actually taking new patients, except her first appointment was in 10 months. I grabbed it, but now I had a different problem. I still needed a checkup this year and all my annual blood tests and monitoring. And how do you do that without a primary care visit? Because if you have a primary care visit, then the insurance won't pay for it in 10 months for another one. I called Medicare and supplemental insurance company about this, but they have no arrangements for such situations. So I've gone without medical monitoring this year and will until next March. This is not good. And in fact, something is starting to bite me at the moment. Keeping things under control and preventing new issues is critical to my quality of life. And also avoiding preventable illness is also critical to lowering future insurance companies' insurance expenses for all of us. And we desperately need more primary care doctors, especially those with training and dealing with ongoing health conditions and older people and people who know a little about themselves and just need help managing. Thank you.
Thank you so
Thank
much.
you.
And thank you all for sharing your thoughts and experiences. Now we are pleased to introduce our distinguished speaker, Dr. Jerome Adams. He's the 20th United States Surgeon General. He's a licensed anesthesiologist with a master's degree in public health. Prior to becoming Surgeon General, he was Commissioner of the Indiana State Department of Health. He is a Presidential Fellow and the Executive Director of Purdue University's Health Equity Initiatives. Thank you for joining us, Dr. Adams.
Well, it is really a pleasure to be here, and thank you so much to Eliana. Thank you to Mandy for leading into this discussion. I'm just going to make some brief remarks, and I want to leave plenty of time for Q&A at the end. And I'm going to share my screen here so that you all can kind of follow me through a couple of slides that I think will drive home the points that I want to make. I want to make the point that we really have to think about health equity and how providing primary care for all will lead to a more equitable society if we're going to actually improve our health outcomes. So let's jump right in. The first point I want to make is that the status quo, as we know it, is unsustainable. What do I mean by that? Well, if you go back to 1980, you will see that our life expectancy has been less than comparable nations, and that has only gotten worse since that time. So you might ask yourself, well, maybe it's because we're not investing as much into health as those other nations are. Well, that's not true either. If you look at this slide, you'll see that the U.S. spends about 2.5 to 3 times as much on healthcare as the other OECD or well established and well resourced countries. So what I term this as in a report I wrote when I was Surgeon General is the U.S. health disadvantage, the fact that we spend more money on healthcare than any other nation, and it's not even close, and yet we get pretty lousy results. The second point I want to make to you is that our system is fundamentally broken, and those statistics make the point. But I also want you to understand that we often talk about health care and think about health care when we're thinking about health. But what we really have is a sick reimbursement system, not a health care system. We spend about 90% of our time, our talent, and our treasure invested in health in the United States on about 20% of the problem. And health happens far beyond doctors' offices, hospitals, and clinics. About 80% of health is determined in the community by health behaviors, by social and economic factors, by physical environments. And we are not going to turn this thing around through our traditional medical model, and particularly by trying to provide more and more expensive and more downstream care. I'm sure many of you all have heard of primary, secondary, and tertiary prevention. I tend to think of primary care as being able to bridge all of those different areas, but certainly having more hepatologists, more cardiologists, more pulmonologists, more intensive care doctors, doubling and then tripling down on this medical model isn't going to solve our problem, because healthcare is not health. We know that health inequities are a major contributor to this U.S. health disadvantage that I mentioned. And health equity is when everyone has a fair opportunity to make healthy choices and can be their healthiest and happiest version of themselves. And so my plea to you all tonight is that you think about how we can provide more people with those opportunities, and how we can use the ability of primary care providers to be that bridge and allow people to know about and to be able to avail themselves of those choices. We saw this during COVID, and many people know me because you saw me on TV quite a bit during the pandemic. But during the pandemic, we saw that there were certain groups that were at higher risk of getting COVID-19. Who were those people? Well, they were frontline workers. They were people who lived in public housing. They were people who often didn't have these social conditions that allowed them to protect themselves from the virus. We also saw that there were people, once they got COVID, who were much more likely to end up hospitalized and to die. And those were people who had chronic conditions, people who were obese, people who had diabetes, people who had high blood pressure. And guess what? Those are more often than not centered in the communities where people don't have the opportunity to eat fresh fruits and vegetables, to have safe places to exercise, to have the opportunities to make those healthy choices. We also see that see this play out in other facets of health. And many of you all have heard about Tori Bowie, the Olympic athlete who died while giving childbirth. You may have heard about Beyonce almost dying while giving childbirth. Serena Williams almost died while giving childbirth. These are examples of how our broken system is failing to address the issues that happen outside of traditional downstream medical care. So many of you have heard of W. Edwards Deming. He's a famous engineer who has said that every system is perfectly designed to get the results that it gets. I showed you the results that we were getting, spending a lot of money, getting poor results. Our system is perfectly designed to deliver exactly the results that we are getting. And another quote from W. Edwards Deming, a bad system will beat a good person every time. So having the best intentions in the world isn't going to change the fact that our system is broken, and it's not going to change our outcomes. So we need to understand that building healthier communities is key, and primary care can and must help drive this change. But this won't happen if people don't have access to primary care providers in their communities, and if those primary care providers aren't in a position to be able to address these social drivers of health. So I'll finish with this slide. And this is really what we need to do. We need to build high opportunity neighborhoods, high opportunity communities where we have quality schools, access to early childcare, green parks and green spaces and parks, quality affordable housing, access to healthy foods, and so on and so forth. We need to build these healthy communities. We need to make sure we have primary care physicians leading the charge in these communities and being the gatekeepers and the traffic cops to help make sure everyone has access, not just to health care when they need it, but to the resources that will prevent them from needing health care, and particularly needing downstream sick care that I talked about earlier so often. So with that, I will stop sharing. Let's see. There we go. And turn it back over to Gabrielle, and hopefully we can have some conversation here about what we've talked about so far.
Thank you, Dr. Adams, for those inspiring words. Please post any questions you have in the chat, and we will get to them in a moment. But first, let me introduce Doctors Aliyah Shafi and Donna Smales. They're my colleagues at Jamaica Hospital in Queens. And Dr. Shafi?
Hi, everyone. Primary care is about relationships. Someone who knows you, your family, your community over time, someone you can trust.
When everyone has primary care, communities are healthier because we can prevent disease.
When everyone has primary care, we'll spend far less money on healthcare as a nation. So there'll be more money to spend on education, safe and healthy housing, public transportation, the environment, public parks, and communities, where it really matters most in health.
We mean everybody. When everyone has primary care, and when communities can get primary care from doctors and nurses who are part of those communities they serve, the health of all people improves, and it improves together. We aim to ensure all peoples receive equal health care and get equal health, regardless of where they live, how much they earn, what communities they come from, or what they look like.
We thank everyone for attending this Teach In, Learn In. We are that much closer to bringing primary care to all because of you guys. We can build a healthcare system that is for people, not for profit. And yes, we can provide primary care to all Americans in every American neighborhood and community. Now, Brian Kaiser will share some of the questions from the audience. Brian?
Thank you so much, Dr. Yaru. Thank you very much, Dr. Adams, for joining us tonight. We're really thrilled to have you. While questions are coming in from the chat, I wonder if we can just get started. If you can tell us some examples about partnerships between communities and primary care clinicians that you have seen work in really effective ways at creating health equity.
Well, great question. And so one example that I will give is one of the biggest drivers of healthcare expenses in the United States and worldwide, and that's diabetes. We know that we can do everything right when it comes to diabetes in terms of what most of us are taught in medical school. We can prescribe the right medications, we can order the right tests, but at the end of the day, one of the biggest predictors, if not the biggest predictor of your success, is your access to healthy and affordable and nutritious foods. And so in terms of partnerships, making sure primary care physicians we're making sure, first of all, people have access to a primary care physician, and then making sure primary care physicians know about and have access to the resources in the community. So food banks, for instance, that can help people access healthy foods when they're food insecure. And making sure we are thinking about writing prescriptions for food. Many people are doing that. Making sure we're partnering with community organizations, and the YMCA in many communities has partnered with primary care physicians to help educate people about how to make healthier choices when it comes to food, and how to find out where those healthier choices exist. Something innovative we're doing in Indiana, we are actually partnering with the Medical Association, and I work at Purdue University right now. The Medical Association, our nursing school, and 211. And for those of you who aren't aware, 211 is available in all states. It's a number you call to access different resources, but we're making it easier for primary care providers when they identify someone who has a need to be able to access 211 to connect people with the resources, whether it's housing or food or other issues that are of concern. And one more thing I want to mention is the medical legal partnership. In many different hospitals, states have medical legal partnerships. So we know that legal issues frequently lead to health problems, and that's something that doctors don't feel comfortable discussing. But if you're being evicted from your home, you're not going to be able to follow your primary care provider's plan. And so making sure people have access to legal services is another example of a partnership I've seen that can help improve outcomes.
Thank you very much. So we have a question from Jen in Oregon. She asks, how do nurses and nurse practitioners fit into this picture? What role do you see for them?
That's a great question. And I just want to acknowledge Eliana in here, who said, please add seniors and disabled people being facilitated to be a real part of the community. I just want to validate that. It is incredibly important when we're thinking about health equity. Health equity, again, means when everyone has access to the resources that they need to be their healthiest selves. And that's color, that's religion, that's language spoken, that's gender, and that includes people who are differently abled. And so incredibly important that we have an inclusive definition of equity when we're thinking about how we help people be healthier. And in that definition also has to include making sure we're leveraging the full array of providers and practitioners and community advocates out there. It's not just doctors. We're not going to be able to solve this problem with just doctors. We have to involve nurses and nurse practitioners. We have to involve community health workers. And at Purdue University, where I work, we have a robust community health worker training and certification program that allows those primary care physicians to have a warm handoff and to be able to have that connection to the community, knowing that oftentimes doctors and nurses are incredibly busy and don't have the ability to literally be in the community the way they would always like to be. Midwives, incredibly important. I think, again, we need to think about different practitioners like psychologists and social workers. We need to make sure we're leveraging everyone so that we can create those healthier communities. But I really do think nurses are key. At Purdue University, we have a school of nursing, and we lean on them very heavily, both in terms of providing primary care, but also in terms of addressing these social drivers that we know will help us address that other 80% that happens outside the clinic and outside the hospital.
Great, thank you. So we have two kind of related questions. I'm going to merge them into one. These are from Michael and Christian. Are there enough medical students? Are enough of them going into primary care? What can we do about this? And how can the medical education system better prepare future healthcare professionals with
Two
primary?
wonderful questions. There aren't enough of any providers, and certainly not enough medical students. We need more nurses. What we need to do is really get into elementary schools and help people from all different communities understand the many different pathways they can take in order to help build healthier communities. And again, for some of them, that means medical school. For some, it's nursing school. For some, it's pharmacy. At Purdue, we also have very robust programs where we're leveraging pharmacists to help provide better primary care in the community. It can be community health workers, but I grew up never dreaming I could be a doctor. Because I'd never seen a doctor who looked like me in my community. So we need to make sure we're doing all we can to help communities that may not always be thinking about a career in health and in healthcare know that that's a possibility. Number one. Number two, we need to help people feel that they can have a successful and a fulfilling career in primary care. Burnout is a huge issue. And I think a lot of people look at primary care when they're in medical school and see that it's a lot of work and oftentimes not the reward that they would think that they would get out of it. The more that we can help create an environment where primary care physicians and where nurses and the whole primary care team feels like they can really change people's outcomes, the more we're going to get people willing to go into primary care and thinking about primary care. And we've got to change our payment structure. We do. Remember W. Edwards Deming, every system is perfectly designed to deliver exactly the results that it gets. As long as our incentives are set up to pay for downstream sick care, then that's what we're going to continue to get, is lots and lots of people presenting downstream with severe sickness. I really like bundled payments. I like thinking about payment reform. And we don't have time to go through that tonight, but I really like a lot of the states thinking about how they can creatively incentivize not just primary care, but incentivize keeping people healthy instead of waiting for them to get sick on the back end. I think those are all going to be key for getting more people going into primary care and making primary care more successful and more fulfilling, both for the patient and for the provider.
Great.
I saw a question also I want to just hit on. We saw a couple of questions in the chat about mental health. And I think we need to think about primary care as more than just what happens from the neck down. We need to think about mental health and integrating that into primary care practices. We need to think about dental care. We need to think about vision care. We need to think about how a lot of the things that are big issues for people are too often pushed off to the side and not addressed in a typical primary care encounter, even though they're the things that are the most important to folks. If you've got dental pain, if you can't see, if you've got mental health issues, you're not going to be thinking about controlling your hemoglobin A1C or taking your blood pressure medication. So very important that we think about how we can integrate and treat the whole body through the primary care visit and encounter, including, like I said, mental health, dental health, and vision care.
Yeah, great. So we're running low on time, but Elizabeth asks, and this may be our last question, how do we influence accountable entities to be a part of the solution and promote primary care prevention as much as specialty care? And I think that's great for this group, who are mostly citizens who want to understand how can we get the powers that be to hear us and actually take action.
Great question to end on. When I wrote my report as Surgeon General called Community Health and Economic Prosperity, it was really about making the business case for health. Businesses are now starting to see that health disadvantage that I pointed out, and the fact that many of you may not be aware of this, but healthcare is the #2 expense for most U.S. companies behind payroll. General Motors pays more for healthcare than what they do for the steel that goes into the cars that they build. So when you buy a General Motors vehicle, you are paying more for healthcare for their employees than you're paying for the steel that goes into your car. It's becoming a matter of economic competitiveness or non-competitiveness for the United States. And when businesses get involved, that's when you see change. In Indiana, we were able to get our legislature to approve $250 million for public health and prevention funding, including really emphasizing primary care in our last legislative session. And we were able to do that because the business community saw it as a workforce issue. We needed to have healthy communities in order to have a healthy workforce and to continue to grow our economy. So I think that's number one. And number two is the issue I mentioned earlier. We need to continue to encourage our legislators to reform the payment system. I'll finish with a story that it's not a great story, but it's a true story. As an anesthesiologist, I've been involved in literally hundreds of amputations in my career for diabetic patients who presented late with high hemoglobin A1Cs, had to have toes and ankles and feet and legs chopped off. And guess what? I got paid for every single one of those amputations. However, I don't get paid for counseling patients about how to eat healthier foods. I don't get paid to ask these patients about what's your community and environment like, and can you go out and exercise? And so we need to change the system, or we're going to continue to get the same results that we have been getting over and over again. And that money, that reimbursement part of it, is a major driver for why we're getting the results that we're getting.
Great. Well, thank you everybody for all your great questions. Sorry that we couldn't get to all of them. Thank you, Dr. Adams, for your insightful answers. And that's all we have time for right now. Dr. Yaru.
Thank you. Thank you, Dr. Adams, and thank you, everyone. We encourage everyone to bring someone new they think would want to get involved in this amazing movement to our next Zoom meeting. We'll be announcing the date and time of that Zoom very soon. And please go on our website, www.primarycareforallamericans.org. We want to let you know about a couple of our upcoming speakers and the amazing Rashika Fernandopoul, MD, the founder of Iora Health, will be speaking on January 23rd on the power of primary care. And in February, Dr. Wayne Altman, MD, chair of the Department of Family Medicine at Tufts, will be speaking on the PC4U legislation in Massachusetts. Join us if you haven't already, and give us your email and your zip code so we can invite you to the next Zoom. Or better yet, please hit volunteer to tell us how you'd like to help, or hit donate if the spirit moves you to help out with a contribution. Once again, we need and appreciate every single one of you for helping us spread our movement across the nation in order to get the change we need and you deserve. Healthcare for people, not for profit. Primary care for all Americans.
Please take a minute to fill out our survey. The link is in the chat. We greatly appreciate it. Thank you everyone for coming, and see you in 2 weeks.